Very happy to bring our pediatric Grand Round speaker to New Haven for Grand Rounds today. And our speaker is Kassa Darge. Kassa is a professor of radiology from the Children's Hospital of Philadelphia. And he's got a very interesting history as well. He grew up in Addis Ababa in Ethiopia, where he did his MD degree there. Then, because of extensive training in German, where he learned since the age of 4, he went to Hamburg, where he did a diploma of parasitology and tropical medicine. Then went on to do an MD degree in Heidelberg in Germany, followed that up with a PhD degree in Heidelberg, and has been in the US for the last 9-10 years, where he's been a real name for himself in ultrasound and ultrasound contrast agents. But Kassa's biggest claim to fame is probably that he came in last night on one of those tiny little aeroplanes from Philadelphia into that tiny little airport that we call Tweed in that enormous rainstorm that I think would have struck the fear of God into anybody. So he made it, he survived, and we're very pleased that he did. So Kassa, thank you for coming, and we're glad to have you.
Thank you. I switched it. Yes. Thank you very much, Rob, for your friendly introduction. Appreciate it. And thank you so much for the invitation to the very famous Yale. I've heard so much about it and wished I would come and visit one day, and it has been possible, and I'm really fascinated. And though it was really stormy in the plane, it reminded me back home when I flew with small planes domestically, and all these shaking was really tough. And when you land here, the most fascinating, your airport is so lovely. That really reminded me, you go out and then you're outside. I said, wow, is this real? That is so nice. Enjoy it. I mean, it's nowadays especially, it's really nice to have such smaller airports where you don't have all these processes to go through, and it was really an enjoyable experience. So, as mentioned by Rob, I work a lot in the use of ultrasound contrast agents in children, and when I heard this lecture with a lot of vascular ultrasound, I said to myself, he's showing the angio studies and the ultrasound. Wow! Now that we have ultrasound contrast agents, we can reproduce the angio studies in ultrasound because you inject the contrast and you can see the connections dynamically and live, and you can do 3D with the ultrasound. So that is something really, you brought us on an idea that you really can combine and improve the diagnosis to a large extent here. Thank you so much. It was wonderful to hear. So the topic of my presentation is the use of ultrasound contrast agent in children for the diagnosis of vesicourethral reflux with intravesical administration. And I wanted to share our experience in this. And a lot of the work we did at CHOP has been a lot of team effort, and I really want to thank my research fellow, Katerina Natalia, and my colleague, Susan Beck, and our ultrasound team leader, Laura Poznik, and especially our very innovative pediatric urologists who have also taken up this new method as part of their routine diagnostic modality. You have to remember that ultrasound contrast agents are as of yet not approved by the FDA. I hope in 1-2 years that this will change, and I have no financial disclosures. So let me just start with a recent case we had. It's a female 4-month-old who had a few months back fever for 4 days, and they did an outside hospital urine culture, and they found E. coli. And in the outside institution, an ultrasound of the kidney and the bladder was performed, as well as a voiding cystourethropy. After the findings were reviewed, the patient was put on prophylactic antibiotic, nitrofurantoin being prescribed. So this is the outside ultrasound. I don't know if we can make the lights a little bit dimmer. Is that possible? Can we make the lights a little bit dimmer? the front lights a little bit dimmer, that would be great. So these are the first outside ultrasounds demonstrate here. This is a transverse image of the bladder. And you see this is on the left side, part of the distal left ureter, slightly dilated. We see the thickened uroepithelium of the ureter. The left kidney, though the cortical echogenicity and corticomedullary differentiation appeared normal, there was dilatation of the renal pelvis as well as the proximal ureter was dilated. At the outside institution, indication patient urinary tract infection, some urinary dilation, and the indication for voiding cystourethropy was made. And the patient underwent a VCUG. This looks like a pulse fluoroscopy with fluorograph images. You see the bladder catheter in the bladder. Contrast was administered. And after filling the bladder, you see this reflux on the left side. There's some kinking. And you note here, and as one of the radiology residents this morning mentioned, this is the drooping lily pattern. So this must be a duplex kidney. Was not so well documented on the ultrasound. So it was reflux in the lower moiety of grade, about grade 3. And then the patient voided, and this catheter was still there. And the colleagues did a cyclic filling, and then they filled again, and again they filled up and demonstrated the reflux again. That's the second filling, and the patient emptied also for the second time. So the voiding cystourethropy diagnosis was grade 3 reflux in the lower moiety on the left side. So 14 months later, the parents bring the girl to CHOP for further follow-up after the 14 months after the outside imaging I showed you. And we conduct, again, ultrasound of the bladder. Yeah, so here the bladder normal. We don't see any terminal ureter dilation. We do see the duplex kidney on the left, slight splaying of the renal pelvis in the lower moiety, not as much dilated as before, but slightly dilated. So at this time, the urologist asked them for a reflux study, and the parents said one of the reasons they came was not to have VCUG, but they knew that we were doing alternatively contrast-enhanced voiding urosonography in place of VCUG. So this is what we call CVUS, and that is the same examination. So 4 months later, they came, and we carried out the contrast-enhanced voiding urosonography. How we do it is we scan initially briefly. Again, we depicted the bladder. We didn't see the ureter. This is, I'm focusing now on the left kidney. The right one is normal. Here again, the duplex kidney. There is slight splaying, but the proximal ureter was also not depicted. So what we do is we first do comparative images with the contrast modality. So nowadays, the scanners allow you to have a contrast-specific imaging modality. One of the features is that the mechanical index for these images is very low. In this case, it's 0.06. And that means low power, so that when you inject the contrast agents, which are composed of tiny microbubbles, so that they don't burst. And the images also provide color overlay for the microbubbles and also provide a subtraction of the background. So this is the same image, the bladder, just when we started, you see the catheter, and this is this parallel image in dual modality. The bladder almost blacked out and you don't see much, and it is a low mechanical index image. So the same for the kidney, you can see everything is black here. This is the shadow of the liver, yeah? And this is the kidney. So this is a dual image, the right kidney. And this is the left kidney here. Everything is blacked out. So after that, we infuse the ultrasound contrast agent. And this is the way it looks like. The bladder is full of the ultrasound contrast agent. This is the regular grayscale. This is the contrast specific, which was completely black before. You see this microbubbles now shining and being hyperechogenic. So this is how it feels when you inject it. The bladder fills with this microbubbles. You can see nicely the retrovesical space. If you have microbubbles accumulating in filling a ureter, you'll see similar pattern here, which you don't see here now. So this was the filling pattern. We observed the filling with ultrasound and then go further to scan the kidneys. So the scan of the right kidney was normal, but look at the left kidney. So, which was completely black. Now you have a whole lot of microbubbles in the lower moiety of the left kidney. Yeah? So this you can also appreciate on the real-time images here. You see them, the bubbles float, filling in the lower moiety of the left duplex kidney. And this is the same image without the dual mode. You have it bigger. Once you know where you're looking at, this is the lower moiety. And this is the clipped, and it shows you the microbubbles in the lower moiety of the left kidney. And we turn the patients also prone. And you can depict that, or you turn the patient in the left decubitus position and you can scan from the back. And this is the kidney from prone, the lower moiety here filled with calyceal dilatation, with the pelvic dilation also. And you see it nicely that it is filling and some of the calyces are dilated. You see that here, the cortical part, the parenchyma, you don't see any bubbles. So you can rule out intrarenal reflux. You can see also nicely with this method, intrarenal reflux. And so with this one, you can exclude the reflux. And this is just the single image from prone where you have it enlarged. So what we have in the end, for this patient, what we did with the contrast-enhanced voiding urosonography, we depicted the same reflux, that it's still present and that it is still grade 3, and we could avoid voiding cystourethropy. So it was we could say that there was no resolution of the grade 3 vesicourethric reflux in the lower moiety on the left. And she went back to the urologist and they decided for now to continue for a year the antibiotic prophylaxis. So next year when she comes again, we'll be repeating the same study. So it's just to say that with the ultrasound, we do achieve the similar or even better results. And the ultrasound imaging for reflux, you would see 10 to 40% more reflux on ultrasound than you would see on VCUG. So in the remaining talk, I really want to specify 3 points. One is the rationale for the exam and how to establish the modality in your department, and a brief future outlook. So there are a few rationales for the exam. One is it is an alternative imaging without radiation. We do know with pulse fluoroscopy you have less radiation, but still this one is one without radiation. And also scintigraphy, though it's lower radiation, still is a study with radiation. And even if we as radiologists know and we can optimize it to make it very low, we're not abolishing the radiation. And parents increasingly are aware about this difference. And this is also propagated by campaigns like the Image Gently campaign, which demonstrate the risk of radiation and advise of potential alternatives for imaging. And you see, this is another case of duplex kidney on the right with reflux in both moieties. And you see the dilatation in the kidney and the reflux in both moieties are depicted on the contrast enhanced ultrasound. And we have to remember that this alternative imaging, parents are aware. In the era of internet, this is something parents demand. And this is just an example of an email. This is from the West Coast I got, who the parent writing that the patient had a VCUG grades 1 and 4 at 3 months and prophylactic antibiotic. And for the further studies, they would like to have an ultrasound alternative. So, but it's very hard to tell a parent from California to fly to Philadelphia, knowing already the risk of radiation with flying is the same as the VCUG. So, but believe me, I can tell you, parents don't believe that. I had the best example. One was I had a patient fly from Tel Aviv because the father was a nuclear physicist and the mother was pediatrician. They refused not to come, and I remember they flew in to have this study done. So I can tell some parents are hard to convince, but I always say, instead of them flying, it's better for us to, as pediatric radiologists, to have these available for our urologists and our patients and be able. This is one of the simplest contrast studies because it's just an ultrasound of the kidney and bladder, and you already do catheterization for VCUG. So it's really not a complicated study. And you will know when you use intravenous ultrasound contrast, that requires more experience. That requires more knowledge about ultrasound and a lot of pathologies and differentials. This doesn't require such intensive knowledge and training. The second argument is you get actually better diagnostic results. It's just not for the radiation absence, but the results are better. You detect higher rates of reflux, which is, as mentioned, above at least above 10%. And you can see even in detail, like this intrarenal reflux, you can also depict it. But there are some comparative studies and meta-analysis of the VCUG or the direct radionuclide studies. And this is a study that compared a number of these comparative studies in a meta-analysis and using a specific criteria for including them. And these studies comprised 30 publications with 2,549 children, and which means 5,078 kidney ureter units. So quite large. And how did what was the results? So just for the VCUG, it was 26 publication with over 4,000 children. And the results were comparing and even taking the VCUG as the gold standard, though it is really, we know it's not really a true gold standard. We see that the sensitivity, 90%, specificity, 92%, and you can appreciate the positive and negative likelihood ratio, all showing the high diagnostic value of this modality. Furthermore, even if you compare, there are fewer studies that compare it with direct radionuclide cystography, the findings are even slightly even more higher because the radionuclide cystography does depict more refluxes than the VCUG, so they are more compatible with the ultrasound, which depicts more refluxes than the VCUG. So in one of the early comparative studies, this is the first generation of ultrasound contrast agents, which was not so stable as the one we have currently. And using simple conventional ultrasound, no fancy methods, there were studies have shown that you can detect about more than 9% of reflux. And what was seen, it was very interesting that the reflux that was depicted in only on ultrasound, 70% were grade 2 to 5. And the reflux that was missed on ultrasound but depicted on the VCUG, similarly, 68% was grade 1. So we were missing with the VCUG higher grade reflux, which is more clinically important. Similarly, when we had a second generation, better contrast agents that we use now, and further advanced ultrasound modality like harmonic imaging, the rate in this one study was 47% increase in detection of reflux. So it depends on the technique you use. One which shows the microbubbles better, depicts them much better than the one which doesn't. And in this case, it was seen again that the 90 of the refluxes detected only on the ultrasound, they were really, as you see from grade, the majority were grade 2 to grade 4, whereas the ones only seen in the VCUG, the majority were grade 1 and 2. So the difference is the more higher grade are missed with the VCUG and detected on the ultrasound. The third argument is availability as a diagnostic option. And I think going forward in the future with the changing field of all the healthcare and the payment method, we should be increasingly aware of that. If you've seen the article in the New England Journal of Medicine with point of care ultrasound, is that not only radiology is doing now ultrasound, but other subspecialties. So I think as imagers, it is necessary for us to have a qualitatively good imaging modality and also experience in the different imaging modalities that are available, so that even if other colleagues are doing it, we should not only be doing it, but doing it with more intensity and be the ones that are to be consulted for different issues and have the more experience on these modalities. Otherwise, as radiologists, we will be losing any connection to even further advanced imaging application to certain, for certain diagnosis. So this is important for us in terms of these point of care ultrasound and changing pattern of medical reimbursement, bundled care, and value-based, to be aware of this alternative modality. And fourthly, the comfort and ease when performing this study should not be neglected. Fluoroscopy and nuclear medicine are large equipment facilities. Ultrasound is smaller and much more pediatric friendly, and the ultrasound scan can be done in different positions. Look, you can do the voiding urosonography with the child sitting on the mother's lap, yeah? And then the voiding can be in a natural setting. I mean, I used to have this a pot with music, so we'll put them on that, and when the child starts peeing, the music starts, and you could scan them from the back, and in a more comfortable environment, one can conduct ultrasound than you are able to do the VCUG. And the parents can be easily present and easily access the child when doing ultrasound. And lastly, though it may not apply directly for us, we have to understand that the accessibility of ultrasound in resource-limited setting, where fluoroscopy and nuclear medicine services may be limited, ultrasound may be much more widespread, and it is easier to possibly get ultrasound contrast agent in such places instead of a fluoroscopy unit or nuclear medicine suite. And there are articles that have pointed out the possibility of using this in developing countries in place of fluoroscopy or nuclear medicine. So how do we establish the modality in the department? There are a few steps we need to consider in doing that. Then one of the first things is we have to select the contrast agent that we need and have it on our pharmacy formulary. Sometimes it happens that the cardiologists are already using for echocardiography the ultrasound contrast agent. That makes life easier because then you have it in your pharmacy. You just have to order it. If not, then you have to apply to have it on your pharmacy formulary. The one thing to check is when the manufacturers produce the ultrasound contrast agents, the main indication is for intravenous use. So we spinned off the intravesical application from that. So the main marketing old studies were focusing on IV administration, not on intravesical administration. So we had to do optimization of these ultrasound contrast agents for intravesical applications. And we have done quite a number of in vitro studies to find out the right dose, the way to administer it, the way to inject it. And there are at least for 3 ultrasound contrast agents such studies, so that it makes the choice for this application regarding the type of contrast agent to use much easier. Currently, we have available 2 contrast agents, especially that are used for such purpose. One is Sonoview. Sonoview is known in the USA Lumason. This is a sulfur hexafluoride gas, and that is, the shell is a phospholipid. And this was introduced in the USA last year, approved by the FDA. All the ultrasound contrast agents approved by the FDA are for echocardiography. So all these used in children or in adults for non-cardiac application is by off-label use. So Sonoview, or as known as in Lumason, we administer 0.5% to 1% of the bladder filling volume, very small dose. The other one that was longer in the US is Optizone. This is from the GE Healthcare, and the gas is a perfluorocarbon, and the shell is an albumin shell. And the dose is even smaller, 0.1 to 0.5%. So tiny amount. Imagine this study done that the images I showed you was 0.2% of the infusion, 0.2%. So 0.2 ml of the ultrasound contrast agent, 0.2, in 100 ml normal saline. Those are the images you saw in the case I demonstrated at the beginning. The difference between the 2 contrast agents, this one is the most widely used. A lot of the studies I showed you with thousands of children is based on the Sonoview or Lumason. And this one does not require any refrigeration. This one requires refrigeration. And this comes with a complete injection set. For this one, you have to prepare your injection set. This one, you need more volume. It comes with a 5 ml volume, and this one comes with a 3 ml volume. Both work, and whatever you have already available, it's best to use. If you don't have, it may be easier to use this and have it on your formulary and use this one. The next thing is for the intravesical administration, we need bladder catheterization, and this is standard catheterization in aseptic manner like VCUG. And we have to remember that catheterization, independent of what you put in the bladder, you may have some dysuria, hematuria, one may get a urinary tract infection from catheterizing. All these symptoms have been described. This is important when I talk about the safety of the ultrasound contrast agents later. And these adverse events have been shown in about 1/3 of the children. Regarding the adverse events of intravesical application of ultrasound contrast agents in children, we have quite a large studies, about 7,000 children, with a total 54 events of adverse events. That is a rate of 0.8%. And if you look at the findings of the adverse events, are that it is dysuria, or transient macrohematuria, abdominal discomfort, and the list, all these are most likely due to the bladder catheterization and not the contrast agents per se. So really, until now, there are no adverse events reported that you can say it is probably the contrast agent, even that. So we don't have any adverse events reported, definitely no major adverse events using it in intravesical manner. Even the use of intravenous, the adverse event, rarely allergic reactions for intravenous, or rarely some local findings of a feeling of pain or heat at the injection site are very infrequent also in children. And in this one specific study with over 1,000 children that was carried out prospectively, the primary objective was solely the safety evaluation of these Sonoview, or what we call Lumason in the USA, and there was comprehensive evaluation with a follow-up after a week. And in this specific group, there was no serious adverse event. There were 3.7% minor events. All were self-limited, and for all the catheterization was most likely, and thus we can confidently say the ultrasound contrast agent for the intravesical application has very high safety profile. We just carried out a prospective comparative study using Optizone, which was not used before. It was carried out under an IND, investigational new drug approval by the FDA, and we did that. And also Boston Children's Hospital did a similar study, and they're still ongoing. And we did also an interim safety analysis, and we couldn't find any adverse events that were related to the ultrasound contrast agent Optizone that was not used much for intravesical administration in the past. So what will be the main indications for doing this study? The question has to be, is there reflux? Definitely. And the other question is there urethral pathology or reflux and urethral pathology? Initially, to focus on the reflux study, it is best to select patients so that we have a learning phase, and that would be best in all follow-up studies, boys or girls. Girls, we can include even those in the first reflux examination, and for screening siblings. It's just optimal way to start this modality in your department. Once you're comfortable with that, and also learn how to scan the urethra, one can include boys also for their first reflux examination. The practical contraindication is simple. If you don't see one of the kidneys, or both, or the bladder on the ultrasound, doing this study doesn't make sense. And this happens especially in patients who have marked thoracolumbar scoliosis. That can happen, that you may not be able to see the kidney properly. So then you may, in these cases, just do VCUG directly. So where should you be doing it? There is the alternative. You do it in ultrasound, or you do it in your fluoroscopy suite. We do it in the fluoroscopy suite. We bring our portable ultrasound and do the study in the fluoroscopy suite because all the setup for the bladder catheterization is easily available there. All our fluorotechs catheterize patients and are very comfortable doing that. And if you ever need to switch to fluoroscopy, you have the patient right there. And in our case, the use of fluoroscopy is significantly dwindling over time. So when we take the VCUGs, there will be even less. But we still need fluoroscopy. We can't close fluoroscopy. And we have a few fluoroscopy rooms. So keeping that study there will at least make further use of the room and the personnel in the fluoroscopy suite. And maybe later one can switch also to an ultrasound suite and have all the setup there. It depends on the place, but both options is possible. And For this study, I trained both the sonographers have now been trained. We have about gradually trained 1, 2, 3. Now we have trained about 3 sonographers and also the attendings. But it's also very important to train the sonographers because they do the bulk of the studies. And it's not a very difficult thing to do once you have the right setup, once they know what they're supposed to be looking for. So that the role of incorporating the sonographers is extremely important. The bladder catheterization is carried out under the same technique like the VCUG. We empty the bladder, and then we have an infusion of the contrast suspension. So depending on the whatever contrast you use, you make a suspension with normal saline and let it run in the bladder. The one thing to remember to make the examination more optimal is to have a 3-way stopcock like this and put the contrast agents in 180 degree here at this level and add a saline, normal saline in a 50 ml syringe on the side. That will give us the possibility to first to inject a little bit normal saline in the bladder when we start. And if it's too concentrated, we'll have acoustic shadowing dorsally. So to dilute it, we can inject a small amount of normal saline too while the infusion is running on this side. The preparation of the ultrasound contrast agents, the infusion, we have to estimate the bladder volume by age plus 2 times 30 and prepare the normal saline suspension for this age group to fill the bladder. And each one, the Lumazone or the Optizone, have specific instructions how to prepare the contrast agents for injection. You have to leave it outside, you have to warm it a little, and that is to be followed in order to have an optimal contrasting. As I mentioned before, it is at least nowadays, a lot of these machines have dedicated contrast modality. And I think if we start now, I mean, that's something we should look to have in our machines. A lot of these machines already have it. Some one may need to buy and add that modality into the machine. It's a low mechanical index machine, and it has color overlays like this. It has the background subtraction like this. One can have dual presentations. And it's also optimized for specific contrast agents. Some are optimized for the Lumazone, some are optimized for the Optizone. So these are really an important modality. If you want more information of each of these modalities and which company has which one, what type, you can find more on the website of the Society of Pediatric Radiology. We start with the ultrasound scan of the bladder. We monitor during the filling phase, and an optimal filling means homogeneous distribution, no acoustic shadowing. You even see the rectum here very nicely. You can see the base of the bladder, you can see the retrovesical space, and when you do the subtractions also, you can nicely see the reflux in a previously non-dilated ureter is nicely depicted. This is a homogeneous, nice depiction of the bladder filled with the ultrasound contrast agent. There are a few pitfalls that I would like you to be aware. Though rare in the US, if you use normal saline from glass containers, which may be available in some countries, here it's very limited availability. The glass containers a lot of times are sealed under vacuum. That means they are desaturated normal saline. So if you put in gaseous solutions, microbubbles, so the air diffuses into the solution and the reflectivity of the contrast disappears very quickly. So this is something one needs to be aware, and this is just a study we had done, and you see the contrast duration with vacuum and without a vacuum sealed container is significantly different. The injection angle, as I mentioned, it should be here at 180 and not 90 degree. and it should be a slow infusion. If you put a lot of pressure, some of the microbubbles may be bursting. And once we have the contrast in the bladder, it takes time to mix. And sometimes you look and you say, nothing is coming. But it's just taking time. Just to make it faster, one could inject a small normal saline flash, and then you see it distributing homogeneously in the bladder. If we have too high or too low contrast agent dose, you see, if it's too high, you have acoustic shadow. There is a lot of contrast here, but it's so strong that you will have dorsal acoustic shadowing. So that's why you use so minimal amount of 0.1, 0.2%, for instance, of the optizone. And it's important to set the ultrasound contrast parameters on the machine correctly with low MI. Sometimes you may be having it very high and you may be bursting the bubbles constantly. According to the regulations by JCO in the United States, we cannot use one vial for many patients, so we have to use one vial for one patient, and unfortunately, you have a 3 ml vial, you use 0.1 ml and throw 2.9 ml, which is a lot of waste, but that's the regulation. But in some other countries, you can use one vial for many patients. But the longer the vial stays, the more it's once opened, deactivated the microbubbles. But you see, even then, that takes half a day or so. There is no significant change in the activity. So it doesn't mean if you put it 10, 20 minutes outside, you wouldn't see any difference. It's still very active. If you have a preceding study, like you do an MR urography and then followed by ultrasound contrast reflux study, is if you have the gadolinium settles and the contrast don't mix very well, either you have to do a flash and mix it, or you have to drain the bladder and inject the contrast. So this is something just one has to be aware. And definitely this is a reflux study, be it with ultrasound or VCUG, should not be done, for instance, after an MR urography, because you are hydrating the patient, you're giving Lasix, and that is all contraindicated before doing a VCUG. So you may have a false negative finding. So this shouldn't be. But even if it happens, this is what is going to happen. So we need to be aware of that. Then once we fill the bladder, we scan the kidneys alternatingly, right, left, we scan it. And we can also scan in prone position, and you see it, and the dual modality helps to identify these. But the dual modality settings, also the settings for the kidneys, should be optimized. Here it's very dark. Here you see the borders of the organs. Here one has to remember there is shine through of the fatty renal pelvis. Then it has to be optimized in this manner so that it doesn't show and confuse with the microbubbles. There is a grading system for the contrast-enhanced voiding urosonography, which is very similar to the one we use for the VCUG in 5 grades. And when we compare the grading systems with VCUG and contrast-enhanced voiding urosonography, this is a comparison of 6 different studies. In 74%, they are the same grading. The ultrasound grade is higher than the VCUG grade in 20%, and the ultrasound grade is less than the VCUG grade in 7%. But the 20% discrepancy here, if you look, is the fact that we find grade 1 reflux in the VCUG up to 65% are actually grade 2 or higher on ultrasound. So what does that mean? That just means on VCG, we are missing the contrast in the renal pelvis. Either it's too diluted or it's too small. And we know this already from the previous old studies from radionuclide studies. There you would see also the grade 1 reflux being grade 2 or higher in the nuclear study compared to the VCUG. The additional step after having introduced it and being comfortable in depicting reflux, it's very easy to do an imaging of the urethra. And one can do a transperineal, just above the scan in sagittal, in the perineal area. And you see here nicely the urethra depicted here, normal male urethra, normal female urethra with vaginal reflux, that's nicely depicted. And you can even see here the posterior urethral dilatation in a case of posterior urethral valve. So these are nowadays, with the contrast-specific modalities, very easy to depict. And there have been studies that have shown the high diagnostic potential, the comparative high diagnostic potential, even for the urethra. And there are some departments who completely do only contrast-enhanced ultrasound and no VCUGs in these patients, and do both bladder and urethra. The limitations of the study, one has to remember, as I mentioned before, it's off-label use, but even the FDA says if we know the safety and efficacy, and we can have an appropriate off-label use, and that is appropriate off-label use. And if you know that 70% of medications we give to children are off-label, then this is one of the other off-label. And other contrast agents like Eovist or so are a lot of them also off-label in children, but we still use it routinely, and we don't even know that we're using it off-label. The second question is the reimbursement. There is the possibility to have an added code to the regular ultrasound of the bladder and kidneys to increase the amount. Currently, we cannot directly charge the contrast, but next year or so, there is high potential that we'll have a CPT code for this study or for the contrast, so that we can also charge for the ultrasound contrast agent. Catheterization is a limitation, but this catheterization is the same issue like you have for VCUG, and so it's not a special problem for the ultrasound study. And in one of editorial comments a long time ago, Sarah O'Hara from Cincinnati made this statement, which I think is very nice, says, no radiation, no bladder catheterization, no sedation, low cost, high sensitivity, and excellent anatomic detail. Now that would be the perfect screening cystographic examination. With all these factors considered, cystosonography is fairly close to the mark, and that's how we also regard this study. In last few slides, let me share with you a few future outlook of this. There is the possibility to do a 3D and a 4D contrast enhanced voiding urosonography, and that has been also recently published by colleagues from Europe. The depiction of the reflux here, and you do a 3D, you have a better anatomic delineation. You can also depict ectopic ureters here in the ectopic ureter in the urethra, nicely depicted on a 3D. So that is something, a potential advancement for the future. And secondly, we can use it intraoperative contrast enhanced voiding urosonography to improve the deflux injection results for reflux. And in this group of urologists, what they did is they injected the contrast. This is the reflux before they put a deflux. Then the first time they placed the deflux, and then they checked again here. So they put another second deflux and checked, and now the reflux was gone. So intraoperatively, they were injecting in the bladder, and trying to detect the reflux presence with the amount of the deflux they were injecting. So they found out that about a quarter required repeat injection, and the success rate at 6 to 12 months was 84% was the ones being controlled this way, compared to 64% where the intraoperative reflux examination was not used. So intraoperatively, also very helpful. So just finally, I want to give you a few take-home points that contrast-enhanced voiding urosonography is a safe and high yield and high diagnostic yield method. Its off-label use in children is increasing, including in the USA, and there are a few advanced applications. And I think for all departments of pediatric radiology department, this is a simple study that we really should consider as having as one of our diagnostic modality options in the department, and offer it to prospective patients and parents. And especially, we have to realize that parents are increasingly aware of such alternatives, and we should have that available in our area so that we can provide this diagnostic option. Thank you very much for your attention.